You've had some great talks here. Earlier, I think Dr. Kasrajian gave a great talk on the sort of outcomes between CEA and transfemoral TCAR. Dr. Abirama gave a great talk with a lot of data with regards to CEA versus transfemoral carotid stenting, some TCAR, and I'm sort of left in this little niche group of IVL, intravascular lithotripsy for carotid artery stenting, and heavily calcified lesions, how to do it. I have done some. Our group has done a small number. I'd probably put it at 15. I think the majority of our patients sort of fit in that high-risk group of both the carotid endarterectomy as well as the TCAR group. So in the TCAR group, the heavily calcified lesion, circumferential, is sort of a high risk. Most people try to avoid doing those cases. We would as well. The other problem, though, is some of these lesions get to be quite high. If they're asymptomatic, we would just manage these patients with best medical therapy. But when they're becoming symptomatic, which is what I'm going to show you today, you're really sort of stuck in trying to figure out what's the best method. And Kasrajian sort of told you that if you have both of these toolboxes in your set, your overall results are going to be better. And I sort of agree with that. We've looked at this. Dr. Kasrajian went over it. I think that TCAR in a subset of patients that are typically pretty well picked early in the Roadster 1 and Roadster 2 trials, the results were actually quite good. And we had similar results in our own group, but what we did see is as we sort of expanded our indications for these, we did have a sort of a slight uptick in strokes. Certainly, half my group, I would say, is probably 70% TCAR. I still probably only about 30% TCAR, but it is a faster procedure. And I think that is why a number of surgeons are going to it. I also think that patients like it a little bit more. Both are easy to recover from, but I do believe that TCAR is a little bit easier, and there is a decrease in the risk of cranial nerve injuries. You can see here, reversal of flow time is quite low. I do think when you start to use some of these more complex cases and you use the IVL, that your flow times are going to be a little bit higher, and with those increased flow reversal times, there's a slight increase in the risk of stroke. Again, you can sort of see this data that Dr. Kasrajian went over again, post-procedural hypertension, cranial nerve injuries, all less with TCAR, and again, maybe a slightly lower risk of death with univariate analysis. Again, there are limitations of TCAR. Really, it's the anatomy. Dr. Kasrajian went over that, and really, its big one is calcium. There's been a little bit of a push from some individuals and some centers to really go after this with IVL. There really has not been much data. I'll go over the data that we have with regards to it. Most of it comes off of what has been done in the periphery with regards to IVL. And IVL, for the most part, is a very safe procedure. It works very well. It's got a very limited risk of distal embolization when you utilize it correctly. And the risk of dissection with it in the peripheral bed below the legs is actually quite good. And you can see this. And this is both in their registry as well as in their randomized controlled trial. So here are some cases. I mean, this is a case that is, because that's pretty much all you've got when you're getting into this stuff. This is a case that I did, heavily calcified, short lesion. The lesion was a little bit high. It was also a redo. None of those things I'm really afraid to do, but I think all of those things, even in an experienced hands of Dr. Abirama, there is a very slight increase in the risk of stroke as well as cranial nerve injuries, and the recovery from it is going to be a little bit more difficult. So adding something like this is the case that we did. Procedural time, again, you couldn't do this case, redo high, calcified in 42 minutes. The patient was monitored on the floor. We put all our patients to sleep when we do these cases. What sort of balloon are you going to use when you use IVL? That's really the trick here, because what you have in your armamentarium is not very good. Most of these in TCAR, you want to do rapid exchange. If you're using the M5 Plus, which is the balloon that you would probably use now, you could maybe use the M4. That's a 5 centimeter long balloon, and the other one is 4 centimeter. But they're over the wire. They're 135, and you're very short distance. Very doable, but sort of painful. They do have an RX. It's the coronary. The coronary balloon goes up to 4.5, which is typically what I dilate with anyway, pre-dilate, is a 4 millimeter balloon, but the balloon itself is a little on the short side, and early it was very slow in the pulses, which isn't a problem when you're under flow reversal, but you could get through it. They really need to develop a tool that, if we're going to go after heavily calcified lesions, is doable for these types of procedures. They should also run a trial, and I suspect that is going to be coming through. Again, here's another one, heavily calcified lesion, sort of a small distal ICA. Could maybe make the argument that that's small. I just think it's underperfused. Again, symptomatic high lesion. And you can see this on the CT scan. This is even windowing down. It's a pretty high lesion. But again, with the flow reversal getting up there, this I would pre-dilate just with the, I like to use the coronary balloon 1.5 and sort of move it up into 2 spaces. You could use the M5+. There are some things where if you use the longer balloons, you want to try not to extend those shocks up above. There's been some reports not written that you can then dissect the distal normal ICA, which has resulted in stroke. Here's another one. This one took a little bit longer. You can see very tight lesion, sort of extends up high. That's going to be not impossible, but difficult to get to endpoint. This was a little bit calcified at the common carotid artery as well, so it sort of extended all the way. And you can see on the original entry point, this is my case, I don't have a problem showing it. The outcome was actually quite good. But I created a dissection, not with the wire going in, but actually with putting the first device in. I think this was a little bit one of the older devices, which was a little bit more common. We ended up treating that, getting across the lesion. The patient actually did well with the flow reversal. We had to extend our stent down a little bit further distally to salvage that. And again, here's just another case of what you can do with it. Not a whole lot of data, small retrospective studies, 49 patients. There's this abstract referenced a concern for procedural safety due to an 8% stroke and TIA rate, three TIAs and 1 stroke. This was out of UC Davis, who has sort of done some of the legwork for doing this. In conclusions, I think TCAR is a safe and effective procedure. I think if I ever have to have anything, I'm going to have a CEA personally. But based on data from various trials, as well as review from our own VQI data, it is safe. You can use IVL in a few, but I would be very selective in it before proceeding and just doing all patients with this. Thank you very much.